I'm Dr. Levi Armstrong, and I am a clinical and forensic neuropsychologist and a full-time graduate professor. Today, I'd like to welcome you all to this lecture on PTSD in adults and older adults. So, just so you all know, I'm recording this because, well, it's Halloween, and I've got two little goblins at home that I'm not missing out on tonight. So if you hear any candy wrappers or wild kid noise in the background, just roll with it. I mean, why wouldn't I be excited about being able to finally collect my dad tax via peanut butter cups collected? I usually make my kids compete to see who can collect the most, and whoever wins gets $20. The good news is they're both very good at getting all the neighbors Reese's peanut butter cups, and so that $20 is a steal for the mountain of chocolate-covered peanut butter joy I get for the rest of the year. So, today, we're diving into post-traumatic stress disorder, or PTSD, and I know we've already covered the neurobiology of the stress response in past lectures, how our brains react to any diagnosis in the DSM-5-TR, and how that fight-or-flight response kicks in. So today, we're zooming in on PTSD specifically, getting into the DSM-5-TR diagnostic criteria, how to assess it beyond the textbook, the neurobiology of PTSD with a focus on how it actually protects us in some ways, and the treatments available for it. And, this is important, I'm going to add in some of those anecdotes and tips I've picked up along the way. There might even be a little "don't do what I did" story in here, so stay tuned. Let's start by getting clear on what PTSD actually is, as defined by the DSM-5-TR. PTSD is classified as a trauma-related disorder, and it has its own unique set of symptoms. The DSM-5-TR tells us that a person can be diagnosed with PTSD if they experience specific symptoms for more than a month following exposure to a traumatic event. We have to distinguish this from acute stress disorder, which is a little different, it's similar. But the symptoms are present for less than a month. For PTSD, we're talking about longer-term effects, and it can be life-altering. And here's where I'm always on a bit of a soapbox, but it's crucial to remember. PTSD as a diagnosis doesn't mean something is broken in the brain. It's really the result of eons of evolution teaching our brains to never forget what threatens us. Think about it. The brain doesn't want to let go of events that were absolutely life-threatening. It's not that something went wrong, it's actually that their brain is too good at protecting them. Combat veterans and survivors of trauma, like sexual assault, they aren't psychologically weak or damaged. They're survivors of experiences that, frankly, no one should have to go through, and their brains are trying, in the best way they know, to help them survive. So treatment starts with taking the shame out of the equation and helping them reframe their symptoms as adaptive from a survival standpoint. To meet the diagnostic criteria for PTSD, we have four main symptom clusters in the DSM-5-TR. The first cluster is intrusive symptoms. This includes things like flashbacks, intrusive memories that just pop in unwanted, and even physical reactions like sweating or an accelerated heart rate. It's like having the world's worst movie just stuck on loop in your head. Next, we have avoidance. This is where the brain tries to protect itself by steering clear of reminders of the trauma. People might avoid certain places, certain people, or even conversations that bring the memory to mind. It's not always rational, it's instinctual, and it's easy to imagine how much that can shrink their world. The third cluster is negative alterations in cognition and mood. This includes things like negative beliefs about oneself or others, stuff like, "I can't trust anyone," or "the world is a terrible place," which in their mind makes sense after trauma, right? And finally, we have alterations in arousal and reactivity, like hypervigilance or an exaggerated startle response. Imagine walking around every single day, feeling as if someone is about to jump out at you. It's exhausting, and it becomes a huge part of their day-to-day reality. Now, even though we're talking about DSM criteria, I wouldn't lean too heavily on just a textbook approach when assessing someone. You can't just sit there asking, do you have flashbacks? Yes or no. It's more about getting into the nuances. Ask open-ended questions and try to feel out what's really underneath their answers. I'll admit, early in my career I got too hung up on criteria, and turns out people don't like it when you treat them like a walking diagnosis. Listen to their story, pick up on what they're not saying, and let silence do some work for you. Sometimes you'll get more in those quiet spaces. All right, let's dig into what PTSD does to the brain. The amygdala is the brain's smoke alarm. In PTSD, it's constantly ringing, even when there's no fire. Then we have the prefrontal cortex, our rational thinking, our impulse control. It's trying its hardest to keep things in check, but in PTSD, it's overworked. The prefrontal cortex is like the tired parent trying to keep the hypervigilant child, aka the amygdala, from freaking out over everything. The hippocampus, too, a big player here. It's involved in memory and is actually smaller in people with PTSD, according to research. Imagine a tape recorder that's broken, stuck, playing the most intense moments over and over. When we're treating PTSD, we're addressing these very real structural changes in the brain, changes that affect how people see themselves, their relationships, and how they process new experiences. Let's talk treatment now. Cognitive behavioral therapy, or CBT, is typically the go-to for PTSD. Prolonged exposure and cognitive processing therapy are evidence-based and effective. With prolonged exposure, you're replaying the traumatic memory with more control. They're watching the movie, so to speak, without flinching, and over time, it loses its power. It's hard work, but the payoff is real freedom from the emotional grip of that memory. On the emerging side, there's eye movement desensitization and reprocessing, or EMDR. Some people think it's a little out there, but there's solid evidence for it, and I've seen it work wonders for certain patients. It's like using eye movements to help process traumatic memories in a less distressing way. The brain doesn't always heal in ways that make logical sense to us. There's also narrative exposure therapy, which can help people create a coherent story around their trauma. It gives a sense of order to something that feels chaotic, helping clients build a narrative they can carry without as much torment. In terms of medications, we have some solid options. SSRIs like sertraline or paroxetine are FDA approved for PTSD. They help with mood regulation, though they're not a cure-all. Some promising research is being done on MDMA-assisted therapy, although it's not mainstream yet. It's like giving the brain extra support to rewire those responses to trauma. Well, that's it for our lecture on PTSD for now. While this is a heavy topic and one that is often mishandled by the world via stigma and shame, I'm confident that you all are the type of professional folks who undoubtedly will help change that. Thank you for listening, and until next time, that is, if I don't go into a diabetic coma from the manna from heaven my kids are bringing me tonight. I'm Dr. Levi Armstrong, and this is a lecture provided via my upcoming new podcast called the BrainDad Podcast, which will soon be available on all streaming audio platforms at the end of this year. All rights reserved and copywritten 2024 via BrainDad Publishing Incorporated.